The next speaker, it's a real pleasure. It's Dr. Phillip Chan. Yes, there he is. Phillip is spending his working life divided between Hong Kong and Bangkok. And he actually, which I find remarkable, I think, you travel to Bangkok every week to spend a few days here at HIV-NAT and do your research. Phillip is a neurologist by training, but also has done training in internal medicine. And I am very fortunate to be on the team that co-supervises Phillip for his PhD. And the topic of his talk this afternoon is neurosyphilis. Floor is yours, Phillip.
Thank you, Peter, for the kind introduction. And thank you for the invitation to present this always fascinating topic. I'm Phillip, and I'm from Surge of the Thai Red Cross AIDS Research Center. A quick note about Treponema pallidum. The causative agent of syphilis, human is the only natural host of this organism which transmits through the transplacental route or sexual exposure. It is well known for its invasiveness and immune evasiveness. And historically, it is believed that syphilis was introduced to Europe from the New World by Columbus' crew, yet modern genomic analysis question about whether Africa could be its origin. So why syphilis matter? First, there is a global surge of syphilis, especially in the key populations. Clinically, the rebound of VDRL titer after reinfection may make the decision between reinfection versus treatment failure sometimes difficult. Further, multiple lines of evidence suggest that HIV do interact with syphilis. First of all, new syphilis can cause transient elevation of HIV viral load and a decline of CD4 count. And activated immune cells in the mucosa of syphilis may facilitate HIV transmission and replications. Reversely, HIV may alter the course of syphilis. For example, neurosyphilis is more commonly seen in people living with HIV, and advanced HIV infection may increase the risk or hasten the course of developing neurosyphilis. And neurorelapse, that means the development of neurosyphilis despite appropriate early systemic syphilis treatment is more common in HIV populations, and so as the neurosyphilis treatment and non-responding CSF parameters. So in this presentation, we will go through the neural invasion, manifestation, laboratory findings, and monitoring of neurosyphilis. And lastly, we'll talk about the landscape of HIV-syphilis co-infection in ART era. So this figure shows the lateral cause of treponema infection in CNS based on data from pre-penicillin era. So in rapid model, the organism can reach lymph nodes in minutes and into the CSF in hours. Thus, a rough estimation of initial CNS invasion in human being would be from hours to days. And the reported rate of initial neural invasion ranges from 30 to up to 100%, although up to 80% will be spontaneously cleared. Around 10 to 20% will end up as asymptomatic neurosyphilis, which may subsequently manifest as early neurosyphilis, like syphilitic meningitis or meningovascular stroke, or late-stage neurosyphilis, including general paresis and TB dorsalis. In general, the time to manifestation of different types of neurosyphilis overlapped with each other from days to years. And asymptomatic neurosyphilis is defined as the presence of CSF changes in the absence of neurological signs and symptoms. It can present at different stages of systemic syphilis, but it becomes less common upon latent stage. In one study, treponema can be detected in 1/5 of primary and secondary syphilis patients. And in latent syphilis condition, asymptomatic neurosyphilis can only be detected in 13.5% of them. In syphilitic meningitis, it presents with classical meningitis symptoms with headache, nausea, vomiting, photophobia, and sometimes cranial nerve palsy. In meningovascular stroke, which manifests months to years after initial infection, it usually involves the distribution of middle cerebral artery, but spinal cord infarct is also possible. General paresis and tabes dorsalis are both regarded as late-stage neurosyphilis, as they usually present 10 years after the initial infection. General paresis is a frontotemporal type of dementia that, besides the cognitive decline, the patients may present with mood and personality changes, classically with mania and grandiosity. And in tabes dorsalis, it refers to the parenchymal disease of spinal cord, especially the dorsal column. Thus, proprioception and vibration is heavily impaired with ataxia, and lightening pain is predominant. Other rare CNS presentations include CNS gummer and myelopathy. And for ocular and octosyphilis, on the other hand, they can present at any stage of syphilis. And they are increasingly reported in the last 10 years, and they are perhaps equivalent to neurosyphilis given the frequent abnormal CSF findings in these two conditions. Laboratory test. The definitive test include dark field microscopy, direct fluorescent antibody staining, and immunohistochemistry and PCR. Most of them are not quite user-friendly because of the sampling issue and equipment requirement. And all except PCR are overall insensitive tests. In a recent meta-analysis, PCR show a sensitivity of 40 to 70% and a specificity of 60 to 100%. The frequently used test in clinical setting is serology test, which include treponema-specific tests such as TPHA and TPPA, and non-specific tests like VDRL and RPR. Both specific and non-specific tests are available in CSF as well. In neurosyphilis, CSF treponema-specific tests are in general sensitive, but non-specific. And CSF VDRL reactivity remains the gold standard for the diagnosis due to the excellent specificity. Let's look at the change of plasma and CSF serology test over time. In systemic syphilis, upon transmission, IgM and IgG will be picked up by the specific test around second week of infection, followed by another 2 weeks, then the non-specific test will become positive. So if an individual presents to you within 4 weeks of potential transmission and the VDRL test is non-reactive, in compatible cases and scenarios, retesting it in a few weeks is reasonable. And a successful treatment is defined as a 4-fold decrease in the VDRL theta, which usually turns non-reactive by the first year after successful treatment. However, around 10% of patients, especially HIV infected, would show a prolonged period of low-level VDRL theta, the so-called zero-fast state. And these figures show the longitudinal changes of CSF treponema tests and VDRL tests in neurosyphilis. In general, CSF VDRL, despite its specificity, the rate of reactivity decreased over time despite the presence of neurosyphilis. And it is therefore not surprising in late-stage neurosyphilis, such as general paresis and tabes dorsalis, it will show a negative CSF VDRL, and sometimes the diagnosis rely on abnormal CSF white blood cell count and protein level. The CSF white blood cell count is probably the most useful parameter in helping the diagnosis apart from CSF VDRL. It has an extremely good sensitivity and specificity of greater than 90% in neurosyphilis. And CSF white blood cell count is also a reliable marker for treatment response monitoring. In contrast, CSF protein is only sensitive but not specific. This is a flow chart for diagnosing neurosyphilis by combining the characteristic of CSF parameters. So in clinical compatible cases, a reactive CSF VDRL will fulfill the diagnostic criteria. And if it is not non-reactive, together with a negative CSF specific treponema-specific test and normal CSF white blood cell count, it is safe to rule out the diagnosis. If CSF treponema test is positive, it is better to stratify individuals based on their HIV and treatment status. In HIV negative or HIV positive individuals on suppressive treatment, a CSF white cell count of more than 5 would be fine enough to consider neurosyphilis diagnosis and treatment. And among individuals not on ART, a higher CSF white blood cell level of higher than 20 would improve the diagnostic yield because untreated HIV infection would also cause CSF phagocytosis. One note about CSF protein is that it is also considered as a diagnostic criteria in clinical compatible cases. And among individuals with low CD4 count below 200, some of them may have low CSF white blood cell level despite the presence of neurosyphilis. Other tests with promising results to assist the diagnosis include the PCR and the CXCL marker. The PCR, however, is not yet included in any internationally approved guidelines, and species and subspecies specific PCR test is currently under development. For CXCL13, it is a B cells chemoattractant chemokine. Its level is elevated in CSF due to the influx of B cells into the CNS during neurosyphilis. And what makes it perhaps especially useful in HIV condition is that CSF phagocytosis and lymphocytes in HIV mono infection are predominantly T cells in origin. So you would expect a mono HIV infection to have a non-elevated CXCL13 level. So treatment and monitoring. This table shows the recommended neurosyphilis treatment from different boards. The first-line treatment is more or less the same, and essentially IV penicillin versus IM proking penicillin plus oral probenecid. And in case of penicillin allergy, IV captriazone or oral doxycycline can be considered. Regarding alternative treatment, the evidence of IV captriazone efficacy in neurosyphilis is by far not clear, as commented by the authors in a recent Cochrane review. However, failure reports of IV captriazone are nevertheless not quite common. This is a treatment outcome study published last year, which compared the efficacy of IV penicillin and IM proking penicillin plus oral probenecid. Lumbar puncture were repeated every 3 months after the treatment until evidence of treatment response. And the authors reported no difference between the two treatment regimens. Besides, CSF white blood cell count and CSF VDRL response are more likely to take place among those on stable ART. As you can see in the figure, normalization of CSF VDRL and CSF white blood cell count happens far earlier than that of CSF protein in the study. Looking at the predictors of treatment response from the same study, beside ART, a low CD4 level below 200 is also a predictor of CSF white blood cell normalization, and perhaps due to the relative lymphopenia in these individuals. Besides, CSF white blood cell count and VDRL are less likely to normalize in late-stage syphilis. And regarding the treatment outcome monitoring and expectations, in early syphilis, such as meningitis, complete resolution of symptoms is expected. But for stroke, cranial nerve palsies, probably degrees of residual symptoms will persist. And in late-stage neurosyphilis, arrest of deterioration but not complete reversal of symptoms is the norm, except CNS gamma. And lumbar puncture should be repeated at 6 months after the treatment. And again, CSF white blood cell count is the most sensitive and usually the earliest marker to achieve normalization, followed by CSF VDRL and lastly CSF protein. And in case of total lack of improvement at 6 months or lack of total normalization of CSF parameter, including white blood cell count and protein at the second year, a retreatment should be considered. So here I would like to share a case in our acute HIV cohort in Thai Red Cross. This is a 21-year-old gentleman who came for HIV testing and found to have Phillip stage 4 acute HIV infection with acute retroviral syndrome. He revealed multiple condomless sexual encounters within the past 60 days. And he had past history of syphilis and was treated once around 5 months before the acute HIV infection with 1 shot of penicillin. And upon his presentation to us, his RPR increased from 1 to 32 to 1 to 128. So we decided to manage him as latent syphilis for 3 shots of penicillin, as RPR was not repeated after the first treatment until the acute HIV infection presentation. So at this point, let me check how many of you will consider a go for lumbar puncture because of the rise of VDRL. A for yes and B for no. Can we use the, okay, so more than half of us will consider a lumbar puncture. But anyway, he underwent lumbar puncture and MRI brain because of the research purpose. So, oops. Okay, this is what we found. He had extreme CSF lymphocytosis with white blood cell count of 105 with grossly normal CSF protein. And paired plasma and CSF VDRL was 1 to 64 and non-reactive respectively. So we sent the sample for CSF TPHA, which turned out to be positive, and our radiologist, who was blind to his clinical condition, reported multiple T2 hyperintensities in his MRI brain, which suggests extensive meningitis. So my second question here, would you consider neurosyphilis treatment in such combination of scenario? A for yes and B for no. Okay. So we have the same thought. So we actually give the patients a neurosyphilis treatment on top of acute on top of the ART. So okay. So we repeated the lumbar puncture at 24 weeks of acute HIV infection after IV penicillin treatment. Unfortunately, although we put him on ART at acute HIV infection, he stopped ART at around 1.5 months before the lumbar puncture. So he had both plasma and CSF viremia at follow-up. But as you can see, despite the HIV viremia in both plasma and CSF, his CSF white blood cell count markedly reduced from 105 to 10 at follow-up, and repeated MRI also show interval improvement of T2 hyperintensities. So to have a better idea about the changes, we analyzed his blood PBMC and CSF sample before and after the penicillin treatment in flow cytometry. And this is what we find. At baseline, 57% of lymphocytes in the CSF were B cells, and compared to only 15% in the blood. And highlighting the B cells expansion infiltration in the CSF, this is in line with neurosyphilis HIV co-infection. As a mono HIV infection, you would expect only T cells in the CSF. And at 24 weeks, the B cells pyocytosis resolved. And the percentage dropped from 57% to now 4%. The CSF-B and T-cell ratio is now more compatible with HIV monoinfection. So, however, after all, it is difficult to tell whether it is an asymptomatic neurosyphilis given the overlapping symptoms of acute retroviral syndrome and syphilis meningitis. And we are also not sure if the development of neurosyphilis is facilitated by the new HIV infection in his condition. So I would like to end my presentation to talk about the landscape of HIV syphilis co-infection in ART era. Regarding HIV on syphilis and treatment outcome, looking back in hindsight and the previous reports about treatment failure and non-responsiveness are perhaps related to the low CD4 level and the lack of ART treatment. As we see in the treatment outcome study last year, individuals on suppressive ART seems to do fine and similarly to those without HIV infection. And whether treated HIV could still pose any effect on development of NS for neurosyphilis remain unclear. And reports about increased incidence of ocular and octosyphilis are plenty in the literature, but well-structured cohort report with participants on suppressive ART is lacking. Besides, the asymptomatic neurosyphilis remains a difficult one to diagnose unless a routine lumbar puncture is carried out like our research participants. And meanwhile, an active screening for visual, hearing, and CNS symptoms whenever a new syphilis is encountered seems reasonable. And regarding syphilis effect on HIV, again, our current understanding about syphilis on CD4 and HIV viral load are based on reports from participants not on treatment. It is not clear if now or new or syphilis reinfection could still alter the CD4 level or say perhaps cause transient HIV viral blips. Given the dysregulated CD4-CD8 ratio is a strong negative predictor of clinical outcomes, and it is common among treated HIV patients. Plus, syphilis is such a common scenario in longitudinal care. It sounds relevant to examine if syphilis could still contribute to immune dysregulation and perhaps persistent immune activation in HIV populations. An extension to this matter is the observation between prior systemic syphilis, but not necessarily neurosyphilis and cognitive impairment in HIV populations. CNS penetration is common at early syphilis based on the pre-penicillin era data, and even it is eventually cleared up by self-immunity. Repeated infection can possibly contribute to intracranial immune activation, and such repeated immune activation is frequently regarded as a contributor for progression of neurodegenerative diseases. And an even less mentioned topic is stroke, HIV, and syphilis. If you look at PubMed, you can find plenty of case reports with this combination. And vascular complication is common in treated HIV populations, but by far there is no formal report that explicitly examines, say, whether prior syphilis or recent syphilis could be associated with subsequent stroke HIV population. I think at least on the clinical and long-term outcome matters, we still have a not unknown on syphilis and HIV. So this comes to the end of my presentation, and I would also like to take this opportunity to thank all the leaders and collaborators in our groups. Thank you.
Questions from the audience to this talk? Yes, there's a question on the left. Please introduce yourself before you ask the question.
I'm Dr. Masliza from ID Physician from Malaysia. I've got 3 questions. Thank you for an excellent lecture. First question is that in Thailand, neurologists treat neurosyphilis because in Malaysia, ID physicians do. Second question is that it's interesting to see the doxycycline for neurosyphilis treatment. Does it really achieve the therapeutic levels in the CSF for neurosyphilis? The third question is that, are you concerned about penicillin resistance as well as ceftriaxone resistant syphilis? Because, we are in the era of antimicrobial resistance. So those are my 3 questions.
So the first question is about the treatment decision, right? I come from Hong Kong, so in Hong Kong, the decision usually based on ID clinicians, but sometimes neurologists will be consulted, and I believe that neurosyphilis treatment is also quite resistant, I mean, from the physician point of view or patient's point of view, because it is quite troublesome because they have to stay in hospital. And for doxycycline, I must say we usually give IV ceftriaxone in penicillin allergy, and I personally do not have much experience in treating neurosyphilis with doxycycline. And for the resistant question, I don't think I am at the best position to comment on the resistance between syphilis and penicillin, but we seldom come across, honestly speaking.
Next.
Hi, I'm Iskandar Azwa from Kuala Lumpur. I just wanted to ask 2 questions. The first question is the necessity for LP examinations looking at the CSF after treatment of neurosyphilis. So practically getting the patient to do an LP already at the beginning is extremely difficult. And then to assess it 6 monthly until the white cell count, CSF white cell count reverts to becoming negative is, even more difficult. I think there's some data to support, as long as there's a 4-fold decrease in serum pre-treatment titer, that's enough to look at treatment response, rather than looking at the CSF. I was wondering whether you could comment on that, firstly. And secondly, the CDC guidelines also recommend treating after a course of neurosyphilis with IV penicillin with an additional 3 courses of benzathine penicillin. The argument being that that treatment of 2 weeks initially is very short. And I was wondering whether you could comment on that as well, please.
For the first question about the first question. The first question is
the necessity of looking at repeat CSFs at treatment response.
Yeah. I totally agree that getting a second lumbar puncture is difficult, but personally, I would talk to the patient, say, hey, this is what we find in the CSF at the very beginning, and it is abnormal. So I personally will try my best to persuade them to get a lumbar puncture, so to ensure that the response is there. But I agree that it seems that there's good evidence suggests that using the blood VDRL theta would be helpful as well. And for the additional penicillin injection on top of the neurosyphilis treatment for the IV penicillin, I personally seldom give the additional cost. Only in those cases that we confirm it is a latent syphilis.
Yeah. Can I have 1 question? Yeah, I'm Siwapon from HIP-NAT. I just would like to know your opinion on regarding the LP in HIV-infected patient. Do you we recommend to do the CT scan, the brain scan before do LP in HIV patient that have a normal neuro physical examination?
From what we do in Thai Red Cross in SURGE, it is not necessary to do a lumbar puncture before getting a scan. And I think if patient has no neurological signs and symptoms and physical exam is normal, and without any sign of an infection like fever, headache, I think it is fine to go for lumbar puncture.
Okay. All right. Okay, I think if there are no further questions, Philip, really thank you very much.